Supraventricular tachycardia (SVT) is an cardiovascular disease. Look at this picture shows that ECG findings, CT, MRI and echocardiogram findings. Detail going on. Introduction. Supraventricular tachycardia SVT is a condition characterized by an abnormally fast heart rhythm originating above the ventricles in the atria or the atrioventricular node AV node. It is one of the most common arrhythmias encountered in clinical practice, affecting individuals of all age groups, although often benign. Prolonged episodes can lead to hemodynamic instability and complications. Definition: SVT is defined as a rapid heart rate exceeding 100 beats per minute with electrical impulses originating above the bundles of gas. It typically presents as an abrupt onset and transmission of tachycardia with a narrow QRS complex on an electrocardiogram ECG. Etymology: the term supraventricular tachycardia comes from Latin and Greek roots. Supra Latin for above, ventricular related to the heart's ventricles, and tachycardia from Greek tachys meaning fast and cardia meaning heart. It describes as rapid heart rate originating above the ventricles, typically in the atria or AV node. Types: 1. Atrioventricular nodal genital tachycardia AVNRT. The most common type caused by Rentry circuits within the AV node. 2. Atrioventricular reciprocating tachycardia AVRT involves accessory pathways such as in Wolff Parkinson White syndrome. 2. Atrial tachycardia originates from an ectopic focus in the atria. 4. Multifocal atrial tachycardia (MAT) involves multiple ectopic foci commonly seen in patients with pulmonary disease. 5. Junctional tachycardia originates from the AV junction. Causes: 1. Congenital heart defects. 2. Electrical conduction abnormalities. 3. Excessive caffeine, alcohol, or stimulant use. 4. Hyperthyroidism. 5. Myocardial infarction or ischemia. 6. Stress or anxiety. 7. Chronic lung disease. 8. Certain medications. Example: digitalis toxicity. Risk factors: 1. Family history of arrhythmias. 2. Structural heart disease. 3. Prior episodes of SVT. 4. Electrolyte imbalances. Example: hypokalemia, hypomagnesemia. 5. Excessive physical exertion. 6. Pregnancy. 7. Smoking and substance abuse. Complications: 1. Syncope. 2. Heart failure. 3. Myocardial ischemia. 4. Stroke. 5. Sudden cardiac arrest. Pathophysiology: supraventricular tachycardia refers to a rapid heart rate, typically more than 100 bpm, originating above the ventricles, often due to abnormal electrical conduction pathways. The pathophysiology involves disruptions in impulse formation or conduction, leading to the characteristic rapid heart rhythm. Step by step pathophysiology. 1. Normal electrical conduction in the heart. The SA node in the right atrium initiates an electrical impulse. The impulse travels through the atria, causing them to contract. The impulse reaches the atrioventricular node, where it is slowed down briefly. The impulse then travels via his Purkinje syndrome to the ventricles, leading to ventricular contraction. The triggering mechanism of SVT. SVT can be triggered by enhanced automaticity, abnormally fast firing of pacemaker cells. 2. Transient circuits, abnormal looping of electrical impulses. Then triggered activity, abnormal After depolarizations leading to extra beats. Most SVT are caused by transient circuits, which lead to rapid and repetitive stimulation of the atria or AV node. Three mechanisms of SVT. A. Atrioventricular Rendrian tachycardia. ABRT. Example: Wolf Parkinson White syndrome. And accessory pathways, extra conduction pathways between atria and ventricles bypass the AV node. The impulse can travel down the normal AV node and return via the accessory pathways, forming a circular loop. This leads to rapid atrial and ventricular activation, causing tachycardia. 150 to 250 BPM. B. Atrioventricular nodal Rentrian tachycardia, most common SVT. The AV node has dull pathways, fast and slow. A premature impulse can cause the fast pathways to the refractory, while the impulse travel slow via the slow pathway. By the time it reaches the ventricles, the fast pathway has recovered, allowing rendry and continuous cycling, leading to tachycardia. 140 to 250 BPM. C. Arterial tachycardia AT. An ectopic focus in the atria fires rapidly. The impulse overrides the SA node, leading to abnormally fast atrial contractions. D. Other forms. Example: junctional tachycardia, abnormal impulse formation from the AV node or junctional tissue. 4. Consequences of SVT: increased heart rate, reduced ventricular filling time, decreased cardiac output, reduced coronary perfusion, can cause ischemia and chest pain. Hypotension or syncope, especially in patients with structural heart disease. Heart failure exacerbation. 5. Termination of SVT. Vagal maneuvers can slow AV node conduction and stop Rentrian circuits. Adenosine or beta blockers can block AV node conduction. Catheter ablation can destroy abnormal pathways. Signs and symptoms: 1. Palpitations, rapid heartbeat. 2. Dizziness or lightheadedness. 3. Shortness of breath. 4. Chest pain or discomfort. 5. Anxiety. 6. Fatigue. 7. Diaphoresis, excessive sweating. 8. Syncope in severe cases. Diagnosis: 1. Electrocardiogram ECG identifies narrow QRS complexes and rapid heart rates. 2. Holter monitor records heart rhythms over 24 to 48 hours. 3. Event monitor used for intermittent arrhythmias. 4. Electrophysiological studies maps electrical activity for precise diagnosis. 5. Echocardiogram assesses structural heart abnormalities. 6. Blood test check for electrolyte imbalances or thyroid dysfunction. Nursing diagnosis: 1. Ineffective tissue perfusion related to inadequate cardiac output. 2. Anxiety related to palpitations and fear of cardiac events. 3. Knowledge deficit regarding condition and management. 4. Risk for injury related to syncope. 5. Activity intolerance related to decreased cardiac efficiency. Disease management: first, medical management. 1. Vagal maneuvers, example carotid massage. 2. Medications: A. Adenosine. B. Beta blockers. C. Calcium channel blockers. D. Anti-arrhythmic drugs. 3. Cardioversion for hemodynamically unstable patients. 4. Catheter ablation. Definitive treatment for recurrent SVT. Nursing management: 1. Monitor vital signs and ECG. 2. Educate patients on recognizing symptoms and self-care. 3. Assist with vagal maneuvers. 4. Administer medications as prescribed. 5. Prepare for emergency interventions if needed. Treatment options: 1. Non-pharmacological lifestyle modifications, vagal maneuvers. 2. Pharmacological, antiarrhythmic drugs, beta blockers, calcium channel blockers. 3. Surgical interventional, radiofrequency ablation, pacemaker implantation in rare cases. Psychosocial medicine. 1. Patient education, understanding the condition and avoiding triggers. 2. Cognitive behavioral therapy CBT, managing anxiety related to palpitations. 3. Support groups, connecting with others experiencing SVT. 4. Relaxation techniques, yoga, deep breathing and meditation. 5. Counseling, addressing fears about long-term health and lifestyle modifications. Prevention measures. 1. Avoiding caffeine, alcohol and stimulant drugs. 2. Managing stress through relaxation techniques. 3. Maintain electrolyte balance with a healthy diet. 4. Adhere to prescribed medications. 5. Regular follow-ups with a cardiologist. In conclusion, supraventricular tachycardia is a common arrhythmia that can significantly impact a patient's quality of life. While often benign, severe cases require prompt medical attention. Effective management includes lifestyle changes, medications, and possibly catheter ablation for recurrent cases. Education and psychosocial support play crucial role in ensuring patient well-being and preventing complications. Thank you. Have a nice day.